Good evening. Good evening to one and all. I'm Dr. Sanjay Chaudhary from the Medical Affairs team of Sun Pharma. It gives me an immense pleasure to extend you all a very warm welcome on behalf of the Sun Pharma team. We all know that the past 18 to 20 months have been tough for all due to the COVID-19 situation. Even now, there is much of uncertainty of the various phases and variants of COVID-19. However, there has been a lot of work and research completed, and it is still going on in this COVID-19 therapy area. It is one of the most widely studied therapy area with multiple studies and publications in the last few months. And as we move ahead, the newer emerging challenges have emerged with the Omicron variant of COVID-19. There is limited data presently and lot of queries about the Omicron variant of COVID-19. To combat it, and the way we handle it and manage this wave of COVID-19, specifically Omicron variant, is also different with a newer evidence and therapeutic treatment options. So this question and answer webinar has been scheduled these to address these queries and understand more in details about Omicron variant, how we can manage the present wave of the COVID-19, specifically with the Omicron variant, more effectively, and to know more about the recent updates on the COVID-19 diagnosis and management with the key experts in this therapy area. The topic for today's session is in line with today's situation, that is Omicron, facts and myths. And I'm very much fortunate to introduce our experts for today, who are renowned pulmonologists with extensive experience in the field of pulmonology and cardiology, especially in connection with the COVID-19. It is really our privilege and honor to have both of you, sir, as experts on this forum. Before we start, let me give the agenda that is there for today's webinar. So today's webinar is mostly a Q&A session where we'll not be taking through the slides, but we'll be directly going through the questions and answers that will be asked by our audience. Before we start, let me introduce one of the experts for today's meeting, Dr. Ajay Narasimhan sir. Dr. Ajay Narasimhan sir is a cardiothoracic surgeon. He is an assistant professor at the Institute of Cardiothoracic Surgery, Rajiv Gandhi Government General Hospital and Madras Medical College, Chennai. Sir is a cardiothoracic surgeon at Apollo Hospitals, Greaves Road, Chennai. He is also a consultant cardiothoracic surgeon at Respiratory Research Foundation of India, West Mambalam, Chennai. Sir has multiple publications and poster presentations to his credit. May I request Dr. Ajay Narasimhan sir to introduce our second expert for today's session, Dr. R. Narasimhan sir. Over to you, sir.
Yeah. Good evening, everybody. Thank you for the very kind words of introduction, Dr. Sanjay. So before we go into the topic, I'd like to make a mention that our foundation, Respiratory Research Foundation of India, was established in 2001 with an aim to spread the message that TB is curable, smoking is avoidable, and asthma is controllable. And we have been at the forefront of respiratory therapy as far as our state and city is concerned. And we have been instrumental in conducting a lot of awareness programs for the public and also some educational programs for the postgraduates. And whatever be the situation, we have risen up to the occasion. And this foundation was indeed the brainchild of Dr. R. Narasimhan. So with that introduction, let us go into the introduction for Dr. Narasimhan. He is a fellow of the Royal College of Physicians of Edinburgh and Glasgow, and is the governor of the American College of Chest Physicians in the South Indian region. And he is currently a senior consultant pulmonologist at the Apollo Hospitals, Chennai, and he heads the Department of Pulmonology and EBUS services there. He's also an adjunct professor, TA Tamil Nadu MGR Medical University and University of Queensland, South Australia. He underwent his training in interventional pulmonology and lung transplantation in Pittsburgh. He has over 32 years of experience in pulmonology, and he's one of the senior most pulmonologists in the country. And he's also on the editorial board of Lung India, Pulmon, Chest, Indian Edition, Indian Journal of Sleep, and is a reviewer for many peer-reviewed journals. He has authored multiple chapters in textbooks and has numerous publications to his credit. So without wasting much time, let us go on to the topic for today. Omicron's facts and myths.
Thank you, sir. So I welcome you both on this discussion and to address the queries related to Omicron variant, sir. So as we all know, there have been multiple questions which we have received related to Omicron. So let us start with a very basic question, of which is one of the most frequently asked question is, how is the transmissibility of Omicron variant of COVID-19 different as compared to the earlier variants?
A very good evening to all of you.
Yes.
At the outset, I like to thank the Sun Radiant group for having agreed to organize this seminar on COVID. It is about 2.5 years now since the COVID wave has started. The COVID series 1 is over. Now the COVID 2 has started. And it has caused so much of loss and life to many people. Not only that, people who have survived this also have suffered because the children have suffered because of non-schooling, small-scale industries have suffered, small entrepreneurs have suffered, big businesses have suffered. A lot of things have happened, and still we are in the process of learning. The new variants are coming. People should not think that the Omicron will be the thing and it will be the be-all and end-all of the COVID. The series might continue, but at a lesser severity. To know more about this COVID, I thought we'd have this in the form of FAQs so that whoever has any doubts can put their questions. And we have also formulated some questions which will be of some interest to the public. So you just your first question was how severe is Omicron? That's your first question, right, Sanjay?
Yes,
What
sir.
you wanted to know.
Yes, sir. Yes, sir.
First, I must tell you, Omicron is a very, very gentle virus. It's a gentleman's virus. It has a lot of differences from the first 3 viruses that you are seeing, the alpha, beta, and gamma, the same group, and the delta one also, the one that caused a lot of havoc, and we did suffer quite a lot with the delta virus. And this is slightly different from the delta virus because it causes a very, very minimal symptoms like the congestion in the nose and some throat irritation and some fever. And it disappears in 3 to 4 days time. It does not take a long time for it. And one of the most important features that one used to notice in the other COVIDs is the loss of smell, which used to be one of the cardinal features of COVID. And that's missing in this. That's because the first 3 viruses were affecting the olfactory neurons. That's one of the reasons why people used to have loss of smell as one of the most important symptoms. And some continued to have this loss of smell for a fairly long period, even after the COVID had disappeared. Some of the long COVID patients will tell you, we've still not got back our smell yet. But Omicron is not like that. It doesn't cause that kind of thing. Just causes some nasal congestion, some sneezing, some throat irritation, some cough. It does not get into the lungs at all. It does not cause pneumonia-like pictures. It does not cause saturation problems. It does not cause any saturation difficulties, dyspneas, and breathlessness. It doesn't go there at all. So the life is just about 4 to 5 days of time. That's the reason why the isolations, all those things have come down. So in other words, we can call this as a gentle virus or a gentleman virus because it does not cause much of the problems. I'm stressing this and taking so much of time because many people are like in the past, they keep checking their saturation and keep calling their doctor. My saturation is 95, 97. Should I take a CT scan? Should I do for the test? Should I get hospitalized? The fear about this COVID is so much. So I heard one of the talks, someone said, if hammer is the only weapon that one has with him, everything will look like a nail only. Must keep on hammering. Everybody thinks it is a COVID, it is a serious COVID. I must go for a CT, I must go for this and that. And this awareness, this thought is only about that.
Thanks.
And what about the Indian clinical scenario? How do we diagnose the different COVID-19 variants and in specific Omicron in this trending time of Omicron? Should we still continue to follow the technique like to keep testing? Earlier in the Delta variants, they used to say increase the testing, only then you'll know how many people are affected, and you can isolate as many people as possible. And you should not allow them to go into the community and all that. Should we still adopt this test technique, or we should slow down our testing and test only the symptomatic guys and all that stuff?
Yeah, when COVID, this Omicron variant was announced by the South African variant, many epidemiologists and many clinicians and physicians felt that it could become a big problem. That's one of the reasons why WHO called it as a variant of concern. But later on, with the South African experience and other places where the disease severity was noticed, we realized that it is not a very serious or a severe disease. So in such a scenario, as I said in the beginning itself, we should not keep adopting the same technique, the test thing. I personally feel only those symptomatic people who have problems should be, if they have symptoms like fever, cough, and this sore throat, only those people should go for testing. I think this indiscriminate testing of people is something that should be avoided, because the moment you notice that you have a sore throat or a nasal congestion, I suggest my patients to get isolated. It is very, very important for people who have other comorbids like diabetes, or when they have some post-transplant pulmonary infections, or when they have some coexisting malignancies. And such people only should immediately go for testing to identify whether it is a Delta or a Omicron variant. That brings us to a very, very important question. Does it mean to say that the Delta is gone forever? Delta is still hanging around. Delta has not gone out. That's one of the reasons why we still keep telling about the vaccinations. So Delta is still around, but the Omicron part is one of the very mild viruses. The last 3 to 4 weeks have given us, in our experience has told us that it's a very, very mild virus. It does not cause any serious problem. So that is the reason why the usual technique of test, I think need not be, and especially I personally, it's my personal opinion, that one need not be checking this in the airports and everywhere. I think everywhere we are doing the testing, the corridors and the planes, just before getting in, coming out of the plane. I think they are all slowly coming. If you can look into the UK guidelines now, they said there is no need for such things. So I think over a period of time, I think that people would evolve to modify the guidelines. As of now, the symptomatology is very important. What you should lay stress on is whether this guy has a lung symptom, lung-related symptoms like saturation drop, dyspneas, and saturation dropping below 90%. That's the time when you should start worrying that it is some other variant or a Omicron with some other comorbid illnesses. As long as he is maintaining his saturation of more than 90-95, the low-grade temperature and temperature dropping to less than this thing with one tablet of paracetamol, I don't think you should greatly worry about. So the strategy should be to identify the symptoms and isolate yourself immediately so that you don't spread it to others. But still, I would say Omicron is there everywhere. It is spreading. The way it is spreading, it's a very, very fast runner. It's a marathon runner. It runs very fast, not like the Delta. If one is positive, all will be positive only. So that's the reason why I keep telling the contact tracing sometimes it becomes a wasteful exercise and expenditure for the government and the families and the persons.
Yes, sir. So as you
Okay,
rightly
just
mentioned,
I'd like to have one follow-up question for this. Now that you say it's your personal opinion, so I just want to extend the question to the surgical specialty. Because I, being a surgeon, what is the current consensus about pre-surgical testing in this time of Omicron? Is it still relevant, or you test to avoid getting caught with the Delta virus?
You test to rule out any Delta virus. That means if the patient has some comorbids, like you are going to operate on a diabetic guy, or you are going to operate on a patient who has some other coexisting comorbid illnesses, in such patients, it is always better to do a COVID test and then take him up for surgery. But if the patient is young and he does not have any I think today's guidelines have come today. They have modified the guidelines. They said one should not be denied a surgery because he does not have a COVID testing. Because the patient is young, he is otherwise well, he doesn't have any problem. Such patient need not be denied surgery because they don't have a COVID test. I don't think they need to go for that. But the people with comorbidities are an entirely different game altogether. You need to do all the possible things because you are still afraid of Delta. Delta is still hanging around. It has not disappeared. The only good thing about the Omicron is if the patient is in an incubation to a Delta, if he gets into the Omicron, Omicron runs so fast, it gives some kind of an immunity and it is pushing the Delta to a corner. So that's what actually is happening. More than 90% of the infections now are all Omicron viruses.
Thank you, sir. Thanks for covering the diagnosis part, sir. So continuing with that, how do we pursue the present guidelines for the classification of mild, moderate, severe in the present scenario of Omicron? And will the management pattern also change considering the Omicron pattern, sir, in terms of guideline recommendations?
No, in terms of this category ABC would apply more for the Delta viruses only. Omicron causes, as I said, flu-like syndrome with a fever, cough, body pains, and running nose, sneezing. And only in some vulnerable people, we have not seen any patients coming with coagulation abnormalities and so on. If they have these coagulation abnormalities and if they have these respiratory failures and so on, when you check the COVID testing, you can find out that. So that brings us to a very important question, the COVID testing. When you do the testing, from the testing itself, the ideal way of confirming the Omicron is by genetic sequencing. But if you have a lab, so the Apollo hospital does it, our hospital does it. We have a lab which gives the N gene and the E gene and the S gene if they do that, and what is called the cyclic threshold value. If you look at the values, you have what is called a cyclic threshold value. The cyclic threshold value means the CT value higher means the viral thing is less. The lower the CT value, higher the viral load. So if you have a S gene dropout, what is S gene dropout? If you have a N some value, E some value, S no value at all. That means S is multiplying very fast. So that is why with one cycle itself, you got a lot of viruses. S is 0. So S is 0 means the patient has got a Omicron variant. So if your COVID report or if your lab is doing the COVID testing for a S gene dropout, if you look at this S value and the S value is less than say 0, that means the guy has a Omicron variant we have got. If the S value also is there and the CT value of the N and the other E values are less, that means the patient has a Delta variant, and such patients have to be treated in a different way. So the category ABC would depend on your values and also on the clinical symptoms. But Omicron alone, I don't think we need to worry. Even in 85-year-old people with Omicron, we have handled them at home. We can always stay back at home if their values are not suggestive of the S gene dropout is not there. So one cannot do a genetic sequencing for all, but if one can depend on this S gene, it's a rough guidance for us to say that this particular individual has a Omicron variant. Ideally, honestly speaking, I don't think these things are to be known to the public at all. Actually, ideally speaking, this should be known to the doctor only.
Okay.
Doctor should see and make a decision and tell it. Now it is in the domain. Everybody knows.
Everybody knows everything about COVID.
Everybody knows. So that's one of the reasons why I keep telling you there are certain things which should be known only to the doctor, because next time they'll go and ask where is the SG, they'll ask, because many labs have got kits, but long back they are not giving this this yes kits. You have these antigen kits. I think those antigen kits will tell you if you are positive or not. If you are positive or negative, that will give us an idea about it.
Yes, sir. Sir, as you give an example of 85-year-old patients, sir, of the management. So what is who are the patients at risk of hospitalization? Although we do understand that the risk of hospitalization is low, but who are these patients who are at a risk, and are elderly risk or no?
Now, people with comorbids and people who are not vaccinated. Okay. They are the two people whom you should be extremely careful with actually. The unvaccinated person is always a problem, because Vaccination gives some protection. The unvaccinated people, there are still a lot of the people who are not vaccinated. If you look into the global population, only 41% of the global population is completely vaccinated. If you take country-wise, I was just going through yesterday, the country-wise vaccination. If you take UAE, more than 90% are vaccinated in UAE, whereas in Ethiopia, only 1% is vaccinated. So it varies, So the vaccination, it does give it. So in them, if the Omicron comes in unvaccinated people, in vulnerable individuals, it can kill. It can run it can. I'm not telling it will definitely kill. It has a tendency to kill. So the point is, unvaccinated people and the vulnerable people, you have to be a bit careful. Because any Omicron, one has to be careful. One cannot say that it's only a flu, I won't worry. No, Omicron can cause problems. Majority of the individuals, 90 to 95% of the people have recovered without getting into the hospital.
Okay. So you say they be at home and isolate themselves, but there has been a lot of changes in the home isolation guidelines in the recent times, especially earlier it was 14 days, then it came down to 7. Now I think it's around 5 days, if I'm right. What is the current consensus? And like, is it from the date of testing or from the date of onset of symptoms? Or what if the patient or the person he still feels unwell? Can his leave be extended like that? I know that's always a case-to-case basis, but general guidelines, what are the general guidelines for this
So
home isolation?
the general guidelines are, if you are vaccinated and you are COVID positive, you can stay in 1 week of 1 week isolation center from the day of your symptoms. So you have symptoms today and you go for the testing and you test positive, 7 days of isolation is enough for you. If you are unvaccinated, if you're not vaccinated, maybe you need about 10 to 14 days of isolation. I think you will need. But ideally speaking, this kind of isolation, shutting himself at home
Sorry,
is.
I can't hear you. Sorry. Hello.
Can't hear me?
No, yeah, now I can hear you. Yeah.
Yeah. So ideally speaking, this isolation and a step further lockdown and restrictions in movements, activity, all these things are extremely good when we did not know anything about it. Say 1.5 years back or 2.5 years back, when in 2019, when COVID came. Am I audible?
Yeah.
Yes, sir.
2019, when COVID came, these things are very relevant because we did not know what the disease was, and it was ideal. We said we will stop the virus, we stopped the planes, we stopped the bus, we stopped the trains, and then we could not do it. Then we said we'll isolate it. Then we said we'll contain it. We did so many things, flats containing, sealing the walls, all those things we did. But ultimately, the Delta wave came and then roughshod over us, despite all these measures. So this opens a serious question whether after that came the vaccine. The vaccine did give us some protection for us. We realized that vaccination is good or natural immunity is good. So if you take our country, our vaccines reached a bit late. So though many people suffered with the Delta, a lot of people developed good vaccination, natural immunity. That's one of the reasons why our this thing is pretty good. We had vaccine. We have vaccinated about 145 crore people, roughly around 140, 142 crore we have vaccinated. There are a lot of people with natural immunity too, because during the period when the vaccine was not available, some were developing COVID, suffered and recovered. Some are with long COVID. So they are all naturally immune people, much better than the vaccinated guys actually. So that means, this kind of isolation and staying aloof and all those things are okay in the beginning, early phase of the illness. This is my personal opinion. Whether it is really necessary at this stage of is still a matter of debate only. That's what I would say. Though I may sound a bit saying, I think isolation is good for people who have comorbidities, who have serious illnesses, serious diseases. Such people are the people who are to be isolated. Otherwise, the isolation guidelines are 7 days as per the government guidelines. 7 days if you are unvaccinated. If you are vaccinated, unvaccinated, you can go for 10 days of this.
Thank you, sir. So continuing with the isolation part, sir. So of course there is WHO guidance on the isolation, but practically, how do we take care of the family members when someone is home isolated for COVID-19 in the same home?
Yeah, as I said, Omicron, there is no worry at all. It will spread whether you are in isolation or not.
Okay.
You do we are picking up so many international travelers who are asymptomatic. They are coming out and you're testing them positive. It's going to be there everywhere ultimately. That's what I keep telling By January, February, it is going to infect the whole this thing community. Everybody. This way it has spread, and we can see this thing
Yes.
from whole globally. It has infected more
Yes.
than 110, 112 countries in a matter of 1 month's time. Actually, it has
Yes,
done
sir.
such a fast work and pushed the Delta to a corner. Actually, the
Yes.
poor Delta is remaining in one corner, waiting for an opportunity because it has its own incubation period. And as I said, Omicron is a very fast runner. It is overtaking it actually.
Okay.
Probably some Israeli doctor, some came, it is giving some kind of a natural immunity or something. But it will not be the end of it. That's what I'm. It is one of the variants.
Yes.
Omicron is one variant with a very fast running. It has given us some breathing space.
You
Instead
mean
of
to say it is
suffering
going to
only.
continue again? Another variant is going to come and it is going to.
Naturally, viruses, as infectious diseases are something which
No,
are going.
that is okay. What I'm saying is, will this peril of COVID continue for our life? That is one.
Yeah, COVID will be there. It is not here. It will not go away from the mother
I
earth.
understand.
It's going to be there actually, but it will be in a different form actually. You can see the different now itself. You see now there are clever restrictions. I would say in the first COVID wave we found a severe lockdown, intense lockdown where people did not go at all, stayed at indoors only. A lot of people, children, everybody, nobody went out. People started working from home. It was an intense lockdown, and we realized that doesn't pay as much. So gradually we have released it, and now we are completely we are putting some clever restrictions. Milk is available, doctors can go, servant maids can go. If you have an ID card, you can go. There are clever restrictions because we are still afraid. I always say we are all suffering from a disease called COVID phobia, not COVID. We are afraid of COVID, not COVID. We are not. So somebody is COVID, man, immediately go and see. You tell him not to come. Please be careful. Wash your hands. Sanitize your hands. So the COVID phobia is much more than the COVID disease itself. COVID is going to be going to stay. That's why I keep telling you must leave this COVID diagnosis, COVID treatment, COVID management, everything to the doctors. Not leave it in the public domain and make people confused because there are going to be some. So I said some variants are going to come. Definitely, there are going to be. It is like a flu virus. When swine flu came 10 years back, we had vaccine for that, and we started. We are vaccinating every year. We keep vaccinating, and it's an RNA. It's a basket. It's like a fruit basket for viruses every time, and we prepare vaccines for it. And every October to this thing March, we tell the people to go for vaccination. Flu vaccine is like that. Like that will be this corona. Corona also is going to stay here, and you will have regular new viral vaccines are coming, and some people may develop disease, some people may get hospitalized, some people might die too. Some people may not get it. A majority will not get it at all. So it's going to be with you. It's not something that's going to. So okay, Omicron Delta is gone. Omicron is gone. Will it be over? No, it won't be over. Some more virologists will have a lot of. Actually, I don't know whether some of you are ready. Ravinath Gupta had said that it's going to be the next variant will be more serious, giving a lot of worries for people. Geez, it doesn't mean it's going to cause problems. The virus will have its own. Each virus, when it mutates, develops some special characters. The Omicron special character is a gentle virus. It doesn't cause much of a problem. Stays with you, disappears, and goes away. That's it. That's how the Omicron variant job is.
Yes, sir. So there is one question from Dr. Venugopal, sir. This query is that if a patient was positive for the 3 to 4 months back or 6 months back, will that person be immune to Omicron presently?
No. It doesn't. Omicron can come in any energy. Vaccinated people are getting it. People who suffered with Delta are getting it. Omicron is just like a common cold or a flu. It just affects and it goes. That's all. Actually, some people come and ask me, I have developed Omicron. Can I get Omicron again, sir, after 2 months? I keep telling them, yes, you can get it. It doesn't give you a lifelong immunity. No. Give some immunity, that's all. You might get in a milder form because you had COVID before. You might get this in a milder form, you may get it. So theoretically, the answer is yes.
I think we have one more question. Like, what is the? I think this question has been asked in the first wave, second wave, and now again. What is the role of antivirals, antibiotics, vitamin C, ivermectin, etc. in COVID-19 with Omicron? I don't think our answer has changed, but anyway, for the benefit of the audience, I would like you to explain.
Yeah. So none of them have any role because when the first Delta wave came, a lot of things came out. We said chloroquine will be good, then ivermectin will be good, then azithromycin will be good, vitamin C will be good. Lot of local medicines came into this picture. All of them have proven that they are not of any use. Then came the antivirals also. Some of the antivirals said they will be useful in mild to moderate cases. You can use the favipiravir. They said you can use the molnupiravir. They said a lot of drugs have come into the market. Now also there are some antiviral drugs are being approved, but none of them have proven to be of any great benefit in this. And especially for this Omicron, in my opinion, no antivirals are at least for the Delta viruses, yes, for mild to moderate cases of this in COVID, they might help. Uh, they have recognized, India has recognized, India also has recognized that. But for this Omicron, the antivirals have got no role at all. They should not be prescribed and people should not be using them. They should be using them only when they have some other comorbidities in the sense of diabetes or other things, and where you are not tested them, they have just isolated themselves, but you don't want to take a chance. Such people only, but otherwise, none of these antivirals and the supplementaries like the vitamin C's and so on are very useful for this COVID. I don't think we should be wasting money and finances on that. It's a wasteful expenditure of the patient's money.
I think 2021, we saw people fight with each other for remdesivir and tocilizumab. I remember so many people calling me up, and remdesivir was such a common thing. Everybody knew what remdesivir was, what its adverse effects, what is its dose, and all that. Even I didn't know in the initial period. But I think all that is slowly phased out, and we are.
Yeah, remdesivir and toci are still there in the market. We are giving remdesivir to people who are not been vaccinated but hospitalized. We do give remdesivir in 3 doses. We give them. Toci is another
But
which we
that is
use.
for the Delta variant, if I'm right,
Yeah,
not for the
but
Omicron.
for this variant, we are not using any of these.
Okay.
So how do we manage these Omicron cases? So when we say they are mostly mild patients, so how do we, what is the management
We
line?
tell them don't do anything, just stay at home.
Okay.
Take the paracetamol if there is
Okay.
fever, take a antihistamine if there is a congestion of your nose, and
Yes.
there's a throat irritation, take some antihistamines
Yes, sir.
and stay at home. No antibiotics. As I said, antibiotics only if you have a coma. Otherwise, no need for any.
Yes. So there are a lot of queries related to vaccinations, sir. So I believe there are certain cities in India who are more than 80% of the population is double vaccinated. Are these vaccines effective against the Omicron variant?
Yeah, we have a lot of questions in the audience. I think we'll just form a cluster of those questions as a follow-up. And one Mrs. D. Vijayalakshmi has asked, if vaccination is the only option available, why do fully vaccinated still get infected? And is it true that immediately after vaccination, if we get COVID symptoms, it means we are
First question,
infected?
that's a very, very good question. If all are vaccinated, why people are getting it? So there is a difference between a natural immunity and a vaccine-related immunity. There are two differences. People who have developed COVID have a fairly good their immunity is definitely different from the vaccine-related. That's one of the reasons why people who have been vaccinated also are developing this disease. They not only develop Omicron, they can develop Delta also. And I must tell you this. Vaccination does not give any great protection for the Omicron because as the way Omicron is spreading, we are now known that vaccination, but vaccination, we are still promoting it to all the people, double vaccination to all the individuals because it protects us from the death. It does not prevent anything else. Vaccine does not prevent spread of the disease to the other person. It does not do anything. It prevents a serious forms of COVID virus. That's one of the reasons why we are telling that vaccination should go on. Vaccination would not help this Omicron because a lot of people who are getting are all vaccinated. All double vaccinated people are getting this. The question now, the next follow-up question you asked me was about the boosters. Boosters are something which one should be very, very careful about. Because it's going to be if you are to vaccinate the whole country, we have a very big budget. I think our country's whole vaccine budget is somewhere around 8,000 crores. And if you are going to vaccinate all the people in the country only for COVID, you should forget about other vaccines. We have other diseases too. Not only COVID is not the only disease that is there. That's the reason why I keep telling if this is something this should go out of the disaster management area to the doctor's domain. Management of the COVID should not be in the hands of the public, and then where they call and ask whether they can take steroids, whether they can go for a CT scan, whether they can come with this test, whether I can do the test, can I repeat a test? So I think the time has come for us to come out of that actually. So coming back to our main question, the boosters, if you take the first shot of the COVID shot, what happens is you develop neutralizing antibodies and maybe some cell-mediated immunity you get. You take the second shot, there is the neutralizing antibody levels go up and the cell-mediated immunity forms good clones, memory cells are formed. This neutralizing antibodies, the first coverage, the first level line of protection or the level of protection wanes after 5 to 6 months. But the second one, the cell-mediated immunity, CMI, which you call as, which are memories are formed, they're all excellent and intact. When you get a COVID, when you get Omicron, when you get some other disease, it sends some antibodies to prevent you from getting a serious disease. It may not be specific, so any viral it prevents. But this cell-mediated immunity becomes weaker. Like our hair is gray, our systems become old, the immune system also becomes old. Immune senescence sets in. We call them as immune senescence. There's an old age sets into the immune system too. For these people, the cell-mediated immunity capacity, the cells to produce the clones come down over a period of time. Such people need a booster. Not indiscriminately all the people. That's why if you look into our country's policy, we not call it as a booster, they call it as a precautionary dose. I think that's what they now call. It's a precautionary dose. It should be given for one of the most important priority should be for the vulnerable people and the people who are the vulnerable people, maybe the doctors, the staff nurses, or the people who work in the hospitals, people with other illnesses and other comorbid diseases. Those are the people who should be going for the boosters because the protection that is offered by the booster is just about you should get with the second booster, about 98% protection means for the year. Maybe another 1%. How you can't go beyond that, another 1% or 0.1% protection you might get it. But people who have these coexisting illnesses are people who are exposed to a large volume of virus, maybe are the people who will benefit from this precautionary dose of the viral booster. In my opinion, as a routine, going for the boosters is not a very, but it is nothing wrong in taking it. If you want to take a booster, nothing wrong in going to take a booster. That's why we do have boosters, precautionary doses that are available. One can go for a precautionary dose and have a booster if he thinks, if he wants to be more protected. But it is not, I think no vaccine is mandatory now. I think we should make it mandatory in some places like schools and other centers where they are exposed to children who can carry the disease. Other places they are not. And booster is not a thing, but booster is, you take it when you think you like to have it. Or some vulnerable populations should go for a booster, not all. This is science. CDC Atlanta's paper very clearly says that the boosters need not be given as a routine for all the people. That's what the CDC Atlanta paper says.
So continuing the vaccination part, there is one query from Dr. Anif sir, who questions that when does the booster dose needs to be taken if a person has been infected with Omicron? After how much duration for the booster dose?
Generally, we advise about 3 months. If you have suffered from COVID, it is better to wait for, if you have suffered from Omicron, you had 2 vaccines, and if you are contemplating a booster, it is better to wait for 3 months, then go for the.
So now, so ICMR has approved some home diagnostic kits, sir. So if you want to share your opinions and guidance on the home-based diagnostic kits presently considering the Omicron wave.
Yeah, that will tell us, the home diagnostic kits will tell us if you are infected straight away. You know? At home you can do and then find out you are infected or not. And for a confirmation of whether it is a Delta or Omicron means you need to go for an RT-PCR test. But it will tell you, suppose ours is a joint family. In our country, a lot of joint families, a lot of people live in one house. So it's not like abroad, where it's a nuclear families, husband, wife, and their kids as all. In our country, you will have 3 generations living in one house itself, actually. And if the oldest guy is about 1992 with diabetes, BP, and all those things, it will be better for a person to be isolated. So if you have a symptom and you want to know, maybe you can do this lateral flow test and then identify yourself, and you can isolate yourself at home. So that's one of the biggest advantages of this. And I would suggest that this is a good way of doing it. Even admissions also you can streamline. So in emergencies, when they come, you can just do a gene expert or the lateral test, which if you can know within an hour the results, if you know, you can decide on whether he should go for a COVID ward or whether he should go for a non-COVID ward and so on. It's one of the good ways of identifying the thing. But then I always ask myself whether this should be encouraged in a large. If it is so, why only for COVID? People would ask tomorrow something else might come. The knowledge explosion is so much, you can't buy anything, keep kids at home. This decision to do the test, isolate themselves, treat, should be left to the physicians, doctors, not to the public.
Yes. Because when too much information is available, I think we get confused.
It confuses, it does not help the person. Too much of information will not help any person. It only confuses and adds a needless expenditure. They spend so much money. I had a person, who was fined for not wearing a helmet, but he had an RT-PCR test. Even safer state, he thought because he drives around in places. He works for a Zomato, it's in Swiggy's guy. He had done an RT-PCR test, but yeah, he says, I have RT-PCR test. I don't mind paying the fee. RT-PCR test costs around, I think 1,000, 1,500 easily it must cost. I don't know exactly how much it costs now. So people are ready to spend money on RT-PCR. And I think you're all aware that once these lateral kits came, that immediate test kits came, they flew off the shelf, in 2 days. They're just not available. People bought and stocked it at home in case you get it. I don't think you need to do that. So, as I said, people are living with a disease called COVID phobia. COVIDophobia. That's the disease than the COVID.
So there are a lot of queries related to diagnosis, sir. So one question is from Dr. Rangarao, sir, who asked the question, is it necessary that the patient should know whether it is a Delta or an Omicron variant? And on
patient need not know.
Okay.
Doctors should know.
Okay, sir. So they need, okay. So continuing the same thing, Dr. Sudhir Anand sir asked, should family members of those tested positive with RT-PCR test also get tested even though they do not have symptoms at all?
No need. As I said, the contact tracing of asymptomatic patients for Omicron need not be done. There is no need for that. Only for symptomatic, you must go for a Omicron. Similarly, you can add one more also to that. If you are tested positive and you are cured, you are asymptomatic, many people ask me, should I go for a repeat test? There is no need for a repeat test. You don't need to repeat and see whether you are become negative or not. No need for that.
Okay, sir. So as you rightly said, so there was one question on similar lines. In case if someone was to do a negative RT-PCR test, after how many days the person needs to do the test in case of Omicron?
Sure, there is no need to repeat any. Once you are diagnosed as this thing, there is no need to repeat it. Similarly, if you are isolated, you isolate yourself, you are afraid that you might have contracted, you isolated yourself for 7 days. There is no need for you to repeat the test and then see. whether you had COVID or go and do a COVID antibody test. Whether I had COVID or not, I want to check. These are not necessary.
So now we move on to the next bucket of questions sir, related to pediatric population.
Yeah.
So these are
A lot of, I
sir,
think it's a very sensitive area that
Yeah.
we need to handle. We've got a lot of questions regarding pediatric thing. How do you think pediatric patients with Omicron behave, and what is the special thing in the management of Omicron in pediatric population?
My opinion, children have behaved brilliantly in this COVID era. The COVID pediatric mortality in COVID has been extremely low. People said in the third wave or the second wave, you have pediatric cases overflowing and all those things. They've all proved wrong actually. They have not developed any serious disease. The mortality rate is extremely low actually. And India had one of the longest vacations in the world, the pediatric age group in India. I
It's
think
still a
more
vacation
than 2.5 years now, and I think another 6 months. I think the first thing that we do is to go and close the children. Schools, we go and shut the schools, saying that children are the very sensitive people we have. That was okay in the first phase. As I said, the first wave, we did not know anything. Now it is 2.5 years into the epidemic. Our knowledge about COVID is so much, it has grown. A lot of scientific data is available wherein you can face the data and utilize the data that is available now very cleverly and intelligently. So I'll give you an example. Children, since they have not suffered, the usual argument for children is that children are the carriers. So you can see in the first wave when they opened UK and all this, the children were the people who brought the virus to the homes. And you should vaccinate these children or not. That's a debate, another debate that used to come. My argument is, if children are to be vaccinated, there is no doubt it's good only. Children get vaccinated, means they don't get the disease. But if they get the disease, they spread the disease. That means vaccination does not prevent the spread of the disease. So the argument does not hold good. On the other hand, we are vaccinating almost all the adult population now. I think, as I said, we have covered about 130, 140 crore. I think Indians should pat on their regime back for this excellent achievement for it. We've done an excellent job with regard to the vaccine coverage. So when so many people are covered, the question of children going to the school and bringing the virus and giving it to the parent does not arise at all. They met, if they non-COVID, they can get any infection from the school. Why think of COVID only? This argument of for COVID's sake, we are closing the school means, as I said, there will be many more variants will be, because the job of the virologist or the job of the doctor is to identify newer and diseases and newer, because I can give an example of this disease called Legionnaires' disease, where when peculiar disease came some 50 years back, when they could not identify, what we did as a medical community was collect those sera and keep it there. And after 30 years after that, we identified it as a Legionnaires' disease and named it. And from retrospectively, we identified. Now what is happening, whatever we are going to identify, because people are putting it in the public. So we know everything. Like this variant is going to come, that variant is going to come. We may have 3 more variants. I don't think you can keep the schools closed for such a long time. If you do that, another 20 years down the lane, we are going to have a generation which do not have any knowledge at all. Absolutely no playing capabilities. They'll forget about playing. They'll forget about tennis, table tennis, badminton, games they'll forget. They'll just sit in front of the computer and do the digital games, which is completely useless in my opinion. You will have more of DCDs at that time, non-communicable diseases like diabetes, obesity, and other diseases, young diabetics, young hypertension you will find. It is time we open up the schools. But the only thing that you must insist is that the teachers who teach, right from the principal down, the principal, the teacher, the staff, the bell honker, whoever, watchman, all of them should be double vaccinated. the double vaccinated for this year. I don't think we should go for, because 30, 25-year-old next year onwards, you come and show me the double vaccine certificate. I don't think it's wasteful expenditure. One should not do that. Relatively, young people are there in their school, they are watchmen, they are double vaccinated this year. We must start changing this so that it is good for the children. It's good for the community, because today's children are tomorrow's doctors, tomorrow's engineers, tomorrow's entrepreneurs. You are making them defunct by making them sit sit at home and make them sit in front of the computer and teach a lot of wrong things to them. Because children have become smart. They don't want to listen to me. They can always say, I can't hear. My video is not coming. My audio is not coming. So many, naturally, people can learn a lot of things very easily on the computer, both good and bad. So children schools should open, schools should start working with all intelligent precautions. Now comes the question of vaccination. But many people ask me whether children should be vaccinated in that age group of 5 years, 6 years, or 7 years. So if that is the case, we should always ask ourselves about the data that is available. See, for example, in adults, we had complications like some people developing the thromboembolic phenomena, people developing Guillain-Barré-like syndrome, people developing some serious problems following COVID, some deaths. So many news we came, my people developed myocardial infarctions and all came actually. But that kind of fear we generally translate it into the children also. If this happens we become emotional. Kids means we are highly emotional actually. But what we should look at is none of these children who have been exposed. Zero prevalence in children is pretty high. At least most of the children have been exposed by now, and they are all immune to this COVID itself now. And we need to have a good data with regards to the pediatrics. Even if there is a 0.1% or a 1% mortality in a kid with a vaccine, I think we should not allow that. Until that data comes, in small kids, it will be very, very difficult to give that data. We have fairly good amount of data in the age group of 18 and above. 18 and above, we have some data in that activity. Such people can be given. And in children, as I said, to prevent a disease, vaccine is good only, there is no doubt about it, but we need to have more data. And as I said, COVID vaccine data, COVID vaccine itself was developed very fast, and the data about that is still emerging. It will take more time for it. But that does not mean we should keep the schools shut for a fairly long period. With all intelligent and clever restrictions and precautions in the adults to prevent them from getting a disease from the kids, it's time we open up the schools.
Yeah, coming from personal experience, I think schools should reopen, because the effect of this lockdown and schools closure forces a great deal of stress on the students as well as the parents, if I'm right, because the ultimately it falls on the one of the parents, because you have to spend some time with them. Earlier it was like you can go out and play. We used to ask the kids to go out and play. Now only if you go out, if the kids go out and play, it's like you're doing something wrong and there's nobody else to play with. So all that is putting a great deal of psychological stress on both the children.
I can tell you another 20 years down the line, if we continue this, I think we are going to have a society that is going to be very, very tough to handle. Because children have not been exposed. They have lost that important years, especially the first 3 or 4 years are the formative years when they learn to connect,
interact with people and all that
interact with children, playgrounds, how to share, how to tell stories, how to share stories. All those things are all gone. All those things are all gone. It is time we start doing that. I have said this in many forums that the biggest damage that has occurred is to the children only because of COVID.
So we have yes, sir. You were asking.
Yeah, you can continue. I think we'll
yes.
Go forward.
Yes, sir. So there is a query from Dr. Hariharan, sir. This query: are there any long-term effects of Omicron infection, just like some patients had fibrosis or something in the earlier waves?
No, in the last 1.5 years that we have, 1.5 months that we have seen with Omicron, and the available data from across the world who have had these Omicron from South Africa. South Africa, they never had any problems at all. They were the first people to say that Omicron is a variant of concern, and they are people to say that Omicron doesn't cause any serious problem. Nowhere they have mentioned any problems like long COVID, need for antifibrotics, and need for other kind of drugs. So Omicron does not cause that kind of a problem, but it's too early to say. I said it's a gentle virus today because in COVID, we are never able to say anything with confidence because what's Omicron today and what Omicron will be after as a 10, 15 days, we don't know. But from the experience of Delta and from the knowledge about the Omicron, from the virologist that has evolved, we are able to say this today that it does not cause any, because by this time when we're seeing the Delta, we had a lot of patients who are developing extensive fibrosis, needing ventilator support and so on. We have not had that kind of problems with the present generation of Omicron. That's why I call Omicron as a gentleman virus.
Yeah. So there was one more question. Can there be a recurrence of Omicron in the same patient? I think you've already answered that.
Yeah, I think I answered it. Technically, the answer is yes. One can get it because it's like a.
So
Then what about co-infection with multiple COVID-19 variants?
That's one of the things that should bother, and that's what I keep telling. They are the people who need to be hospitalized and identified whether it is Delta, whether he's likely to develop symptoms, whether he needs to go for biomarkers and so on. Otherwise, if the patient is a straightforward S gene dropout, Omicron means I don't think you should do any test for these biomarkers. You don't need to do any test for any other say coagulation things, D-dimers and so on. You don't need to do any of those things. That's the domain of the hospital. They must be in the hospitals as people when they have comorbid, when there is suspicion of a multiple co-infection. They must be in the hospital and diagnosed. That's a different story altogether.
Yes. So there is a, yeah, Dr. Just
No. I think that you were supposed to say some question. I think there's some audience question, right?
Yes.
Yeah.
So there is a query from Dr. Ganpati, sir. So sir is asking at what point of time can you resume your physical activity like walking, treadmill, cycling post COVID-19 infection?
Now, if the patient has Delta, this question was very extremely relevant when the Delta wave was there. No, we used to tell them to be very, very careful because we used to check their D-dimer values, we used to check their CT scans, and when they were abnormal, we used to tell them we should recheck after about a month, go for a check, then after 2 months, have a review, and then take a decision. With Omicron, I don't think we need to have any such. But if they recover extremely fast and they get back to absolute normalcy, and they can be back to normal. I don't think there is any cutoff rule or anything like that when they can start. It is the individual capacity. That's it.
I think we are reaching the end of the program. So we have some couple of closing questions. This is my own personal question. We recently read an article in the European Union saying that one of the countries have removed the mask and vaccine mandate and treat COVID like flu. They have given a categorical statement. You just learn to live with it. Treat COVID like flu. You don't need to be worried about it anymore. Are we okay to give such categorical statement, or are we still too early in the face of the disease? Or I think you should remove the mask and vaccine mandate. Is it correct?
Mask cannot be removed. I don't think that's a right way of doing it. We should learn to live with the COVID. I agree. Definitely, we must learn to live with the COVID. It may be like a flu, they have said. I would not call it as a, because the flu and the common cold are different. Flu can kill people, whereas common cold does not. Rhinovirus, common cold is caused by a rhinovirus, whereas a flu virus is caused by the influenza. The peak of influenza epidemic, the SARS epidemic, the swine flu epidemic, the avian, all this, they kill it killed quite a number of people. There were mortalities too. You can treat it like a flu, yes, no doubt about it, but you must be careful with the flu. So you must be careful with the flu. You will learn to live with the COVID is correct. But removing the mask is something which I would not suggest at this stage because we are too early in the phase of this. We cannot get away with the mask. But isolation, yes, maybe. I think there is a serious thinking that should come from across the world. I think it has to come from WHO. Across the world, it must come. Whether at this stage, after 2.5 years of knowing about the disease, keeping a seat vacant by the side, running around with 50% occupancy and all those things, whether it is worthwhile or not, I think some more data has to emerge before we say that. In my opinion, one should learn to live with it. Means one should learn to live. If it develops a natural immunity, even if you are exposed, in the if you look into the first this statistics, if you see when the peak of the Delta wave, when in March, April, when our country was going through the Delta wave, when we were reaching the peak, some of the districts did not have any Delta at all.
Yeah.
3 or 4 districts, What does it mean? It means they had a fairly good natural immunity. It does happen. So I think that the day will come. Maybe it may be another 6 months or 7 months of our wishful thinking. As I said, we need to learn. And I always say, this fear will continue as long as we fear Corona. Yeah, all these questions will continue as long as we keep this COVID as a disaster management area. It's still in the disaster management area, not in the doctor's listing yet.
Of course.
What is your final take-home message?
Yeah.
We'd like to conclude the program with this question. What is your final take-home message for the public, for the doctors?
My final
for the
message
officials?
is, I kept on telling right through my talk that COVID should be the domain of doctors. We should leave it to the doctors to handle it. It should be taken over from the public domain. It should not be a disaster management area. It should not be the area of the public health is in concern. First 1.5 years, yes, it is a public health concern. We did what all possible. We have gathered a lot of knowledge. We know how it spreads. We know what it causes. We know one should wear the mask. All those things have come. Now we have reached a stage where this should go into the hands of the doctors. Doctors should treat the patients. They must come to the hospital. Patients who need isolation have to be decided by the doctors. Patients who need hospitalization have to be decided by the doctors. What tests are to be done should be decided by the doctors, because too much of information that is going to continue on this kind of illnesses may not be a good idea. It does not mean, I'm not telling that public should not know about it. They must know about the disease. They must know how to take care of it. They must go and ask doctors about the question. They must learn themselves about the disease. Suppose someone has a heart attack. I don't think there's anything wrong for an individual to know about the heart attack. What is an angiogram? How is it done? How is it superior? Such questions he can do and ask himself. But if you make it as a public health thing and keep it, there will be a lot of needless confusion. A lot of people will land with angiograms and so many other needless and costly investigations that may happen. So my final advice is, it is time for us to move this from the public disease area to a medical community and a more professional approach. I'm not telling that there is no professional approach in epidemiology, and there is an excellent, we have got a lot of data, scientific data is available now. We know how to form the guidelines, we have categorized the diseases, we know how to handle it. People have a lot of experience has been gained. It is time for us to leave the public in a more peaceful manner so that they can concentrate on their work instead of concentrating only on the COVID. They must get back to their work, they must go to office, share the other experience and share their experience with others also. That will be my final take-home message. Because putting out the numbers in the paper is not a is something that's very, very easy to do, because it's available there everywhere in the data. You can keep on sharing that experience to everybody. And that's not a very big thing to do it. More important than that is to how to get along and live with COVID is what is very, very important. And with that message, I think I will hand it over to Sanjay. I thank you, Sanjay and Arun Rangta, Pritham, and the other stakeholders who have made this live webinar, national live webinar possible. Thank you.
Thank you. Thanks for appreciation, sir. So before we conclude, I would also request Dr. Ajay sir also to put in the final comments. Sir.
Yeah. I would like to talk about it more in the surgical point of view.
Yes, sir.
Because me being a cardiothoracic surgeon, and even though the Omicron is considered a gentle virus and all that, I can see the toll it is taking upon the healthcare personnel. Because even though the symptoms are mild, the healthcare personnel are being forced to stay at home. The doctors, the anesthetists, the surgeons, and the people who work in the paramedical staff, they are being. So I think the pre-surgical testing still plays an important role, because at the time of anesthesia and all that, the transmissibility is high. Even without all that, the transmissibility is like very, very high in Omicron when you compare to the other Delta variants. So I think we should still be careful, as Dr. Narasimhan said, it is not over, and we should always be on the lookout for a Delta variant also. And I think we hopefully this will be some light at the end of the tunnel, and it might give us the protection that we need against the more severe forms of the disease. With that, I'd like to conclude my closing remarks.
Thank you, sir. So we have run out of time, sir. So although we have received multiple questions, but we
yeah.
won't be able to answer them. So on a concluding note, on behalf of Sun Pharma, I would like to thank our experts, Dr. Ajay Narasimhan sir and Dr. R. Narasimhan sir, for sharing their enormous experience and addressing all the queries which we received today related to COVID-19, specifically the Omicron variant, and providing valuable practical experience on COVID-19 management. I also thank all our audience for joining this scientific session, and we believe it has enhanced our knowledge on the Omicron variant of COVID-19 and will help take better and effective care of COVID-19 patient care. At the end, I would also like to thank our entire Sun Pharma team as well as the backend team for their kind support in making this event possible. Thank you once again and stay safe. Good evening. Thank you. Thank you all for joining.
Thank you.
Yeah.
Thank you.
Thank you.
Thank you very much.
Yeah.
Thanks, sir. Good night, sir.
Thanks,
Thank
Arun.
you.
Thank you. Thanks, sir. Bye-bye.
Bye bye.